I know some people here are extremely knowledgeable, and some of this might be something you've already seen, and for some of you this may be very novel, but this is certainly not everything that's happened over the last year. It's just that I thought these are the things that are most important for us when we're seeing people that have direct correlation with what our care is today compared to a year or two ago. And so the first thing I'm going to talk about is there's a new system actually out there that's going to replace the Gleason score. I'm assuming you all know what Gleason scores are. That is actually on the way out, and it's going to be replaced with a new system, and I'll talk about that briefly. And then there's some new screening recommendations from the U.S. Preventative Task Force, which are just coming out this year, and I'll go over that. And then I wanted to spend some time talking about some new stuff for metastatic prostate cancer, and these are people who are first discovered to have metastatic prostate cancer. And these are people that the terminology we use is castrate sensitive, meaning they're still sensitive to their first-line hormonal therapy. So I'll talk about that. See if this works. So what is going to be replacing the Gleason score? Well, it's going to be called the prognostic grade groups. One of the problems with the Gleason score is that these days no one gets a Gleason score less than 6. So why do you have a score from 1 to 10, but you really start at 6? It doesn't really make any sense. The second is that we have 2 different categories of Gleason 7. We have a Gleason 3+4 and a 4+3. Are you all familiar with the Gleason score? Okay. So the first number is what's the most prevalent histology, and the second is what's the second most prevalent. But Gleason 3+4s behave very differently than Gleason 4+3s, yet we lump them together. That doesn't make any sense either. And then Gleason 9 and 10s, even though they're different, when you look at data, they're completely superimposable. There's no difference clinically between a Gleason 9 and a Gleason 10. So why do we separate them? So these are some of the real problems with the Gleason score. So the pathologists have gotten together, and this is what they have proposed, and this is what's coming. And actually, we in our pathology department, the pathology report comes back with both. It talks about the group score and then the Gleason, just for people who are still talking Gleason. But that's going to go away. I'm going to only be talking in the future about group scores. So group 1 is anything less than a Gleason 7. Group 2 is the 3+4s. Group 3s is the 4+3s. Group 4 is anything that adds up to an 8. And Gleason 5, they've combined the 9s and 10s. So this is going to be the new scoring system. It's not too complicated. And what I'm going to show next is just some data looking at patients who've had their prostate removed and separated by this new grade grouping score, and shows what percentage of them still have an undetectable PSA over time. And the top line, the green, is people who are group 1. Then the next orange line is group 2. Blue is group 3. And you can see, remember the old 2s and 3s were both Gleason 7s. Look how differently they do. Big separation of the curves. And then this is the group 4, and this is the group 5. And so you can see that it's a much more accurate system to predict how are people going to do than the old Gleason score. So stay tuned for that. That's going to be coming. Well, it's already coming. It takes a little while to trickle down. So the next thing I'm going to talk about is screening. Screening for prostate cancer has really been up and down and up and down. One time when PSAs first came, everyone was supposed to be screened, and then they said, well, no, really you shouldn't screen. And one of the biggest proponents of that was the U.S. Preventative Task Force, and in 2012, they actually recommended no screening for anyone. Now, fast forward to 2017, and they've really taken a careful look at really all of the data. And this is directly from the U.S. Preventative Task Force website. And so, based on their review of all the literature, I think this is a great pictorial. If you start off with 1,000 men, and they're offered PSA-based screening, of those 1,000 men, 240 of them get an abnormal PSA, so about a quarter of them. Now, of those 240, only 100 of them are going to turn out to have prostate cancer. Okay? And then from them, about 80 of them will decide that they're going to have some kind of treatment. Okay? Not everyone decides that they want therapy. And of those 80, over here is pictured when they get it. 65% of them, or 65 of them, will get treatment right away, and 15 will delay their therapy and eventually will go on to get therapy. The caveat is, on this side, these are the number of people who get some kind of long-term toxicity from the treatment, either erectile dysfunction or urinary problems. And so really the problems that they get are not trivial. Of those 80 who get treatment, 3 of them avoid developing metastatic disease. And actually about 1 to 2 patients' lives are saved from all this screening. Yes?
So 3 or 4, so 77 get metastatic disease?
No. 3 development, 3 are saved, no, I'm sorry, 3 are saved from developing metastatic disease as a result of the screening, but it doesn't mean that 77 get metastatic disease.
3 out of 80.
3 out of 20.
3 out of 80 get metastatic disease, and 1 and 2 don't.
No. 3, because of the screening, there are now 3 fewer patients who develop metastatic disease. Okay? And 1 to 2 lives are saved. So when you start off with 1,000 patients, at the very end, you save 3 people from developing metastatic disease, which is debilitating, and you've saved anywhere from 1 to 2 lives. Is that good or is that bad? Well, probably the best thing to compare it to is mammograms, because everyone says that mammograms are a great idea. If you screen 1,000 women for breast cancer with mammography, how many lives do you think are saved? Any ideas?
Not a lot.
2. 2. Very comparable. Yet this is controversial and mammograms are straightforward. The difference, though, is that most women who develop breast cancer don't have long-term toxicity. But in prostate cancer, a lot of patients develop long-term toxicity. And so that's the good and the bad of screening. It does save lives, but it comes at a cost where a lot of people are, I guess you could call, injured by the treatment long-term. And so based on all of this, the new recommendations that they're going to come out with are as follows. If you're between the ages of 55 and 69, the decision should be between the clinician and the patient, and it's based on understanding the potential harm and the potential benefit. And then for men 70 or older, they're recommending against screening, mainly because it takes many years from screening to when you save a life. And there's a lot of competing problems that could lead to the patient's death that may be independent of prostate cancer. So these are going to be the new recommendations. This hasn't been finalized, but this is very likely the way it's going to come out in the next month or 2.
Brian, what does C grade and D grade mean on that? What is that?
So D means like strongly against it, and C means equivocal. A would be you must screen. You know, it's an absolute. So yes.
In the 55 to 69, are you saying you're going to talk to the patient, decide whether to do a PSA or not do a PSA?
Correct. That's their recommendation.
What about men under 55?
So these are for people who are at average risk. It's completely different for people who have some reason to have a higher risk of prostate cancer, either a family history or because of their ethnic background or because of, I'm trying to remember what else. If they have a genetic predisposition, for example, if they come from a family that has like Brachytherapy, which is a gene that makes you susceptible to developing prostate cancer. So those screening is recommended, but this is for average risk patients.
I have a disconnect.
screening usually involves PSA testing and sometimes digital rectal exam. Now, if the screening shows an elevated PSA, then you can go on to get a biopsy and all that. Once you're at the biopsy stage, you're not at screening anymore.
It doesn't apply to somebody who's had a biopsy.
No, these are people who really have no history of any prostate problems, no history of an elevated PSA. These are just people who go into the doctor's office and say, I'm here just to get my annual checkup, I feel healthy, type of person.
And by the way, we don't necessarily agree with these screening recommendations. This is what the National Preventive Cancer Force says, but that's not necessarily what Dr. Mannion and I think about it.
Are you going to tell us what you think?
Yeah, I'll let him go first.
Yeah, I recommend screening as long as the person understands that the treatment could result in some long-term toxicity. As long as they understand that, I think screening is good. I tell women who are in the right age group they should get mammograms, so I think the same thing should be true for men and prostate cancer.
Yeah, and my opinion about the 70-year-old thing is that's really kind of BS. I mean, I think, because there are people that are 75 that are, I'm 64, they're in better shape than I am. You know, and to not give them an opportunity to get treated, I think it's just crap. So my feeling about screening would be if somebody's over 70, you know, we have to look at their overall health. You know, if they've got heart disease and their kidney failure and they're basically, not healthy, then yeah, I wouldn't screen that person. But if somebody has a 10-year life expectancy and they're over 70, I don't see why you wouldn't screen. So I think these recommendations have to be taken, with some degree of personal discernment.
Yeah, I was 69 when the biopsy showed I had Gleason 9 cancer. And, I was right on the borderline at 70, but, I feel finally when I found it and taken care of it, I'm alive now. So,
If you look at the makeup of the U.S. Preventive Task Force, the former recommendations was chaired by a pediatrician. The current board is chaired by an internist. But even many of the doctors on the panel don't have, at least not in the biographies that are on the website, a lot of, experience in the trenches, which bothers me a heck of a lot. A lot of them have positions where they use statistics a lot. And, we're patients. We're not data points.
Was the 2012, recommendation about the screen, has that been overturned? Has there been any other news?
Well, this is the same group. The same group that said no in 2012 is now going to say what I just showed you. The other thing about the 2012 panel is that there was no urologist on it. They were not allowed to access all of the literature. They were given literature by the government, so you can only base your recommendation based on what we give you. You can't look elsewhere. So it was a very...
I don't know that I've talked to a doctor in my 5 years of dealing with this that has even agreed with that.
Yeah, but there are some physicians out there who just read what these people say, and they say, well, they must know what they're talking about, and they just follow what they read. Yeah.
Mine went metastatic years ago. Is there any benefit? I mean, does this apply, or is this for just newly diagnosed?
These are for people who are otherwise healthy, who have no known prostate problem, and sort of a healthy person walking around in the community. That's all that this stuff is relevant that I've talked about so far for.
This is about the healthy people walking around in the community.
All right. Any other questions? So I'm going to move on and talk about metastatic prostate cancer. And again, really talking about metastatic disease when it's first found to have spread. So that's the situation that I'm primarily going to focus on. And so one paper that I thought was very interesting that came out just a little under a year ago. It came out in Journal of Clinical Oncology, which is kind of our Bible. If something's really good, that's usually where it ends up, at least in the medical oncology world. So the title of this kind of says it all. It says improved survival with prostate radiation in addition to androgen deprivation therapy for men with newly diagnosed metastatic prostate cancer. So many of you may know that the standard of care from 1940s up until this paper, essentially, has been if you have metastatic prostate cancer, you go on hormone therapy. That's it. And it's not, and really the things hadn't changed. A lot of things have been tried, but nothing really had been proven to change survival beyond doing that, really up until just a year or two ago. And so the thought has always been, if it already spread outside the prostate, there's no point in doing something to the prostate, kind of the cat's out of the bag. And that was the thinking. And so what this group did was they went back and looked at the National Cancer Database. There's a database that follows every patient with cancer in this country. And they looked back and they looked at people who were newly diagnosed and they compared people who got their prostate radiated anyway versus people that just got the standard, which was the androgen deprivation, and looked at how did they do over time. And it was a long paper, but this was the important graph. In the yellow line is the overall survival over time of people who just got androgen deprivation. And you can see that over time, people start passing away from their prostate cancer. However, if they got radiation, that's the blue line, and you can see that they survive much longer than the other group. So for example, half of the patients, at least in this data, had died by about 3 years. But if you go out here, this is more like 5 years. This is a 2-year difference. In the cancer world, having a treatment that extends someone's life by 2 years on average, or maybe even more, that's huge. Now, the criticism of this data is that it was retrospective. And so is it possible that maybe the people that got radiation were healthier, maybe they were younger, maybe they had a different Gleason score, all those kind of things. So they tried to look at that to say, was it really true for all people, or is this some selective bias? Yeah.
Was it one bottle of wine or two that I owed you for showing this study?
Maybe more.
So if you guys don't read articles, you probably don't, this probably doesn't mean anything, but basically what it is there's something called the hazard ratio, and look, you just want to focus on the dotted line. And so what they looked at is they looked at each one of these groups. They looked by age, by PSA, by Gleason score, by T-stage, whether they had lymph nodes. And they said for that subgroup, if the dot is on this side of the dotted line, it means it favors radiation and androgen deprivation. But if the dot is on the other side, it means that the androgen deprivation is better. And if the dot lands right on the line, it means they're the same. And you can see that for every group, it didn't matter if they were young, old, low PSA, high PSA, all of them benefited by having radiation. I didn't show this, but there's also some data showing that surgery has very, very similar results. So basically, it's not necessarily the radiation itself, it's doing some local therapy on the prostate, even if it has spread, seems to make a difference.
So how do you define metastatic disease? Is it beyond the lymph nodes? Is it
Beyond the lymph nodes.
beyond the lymph nodes?
Yes.
Okay.
Yes.
Clinically, how do you determine metastatic? Is that just a high Gleason score?
No. So if the cancer is found outside of the prostate and outside of the draining lymph nodes, if it's outside of those areas, it would be called metastatic. So if you have a spot in the bone,
Is it from exploratory surgery or something like
Oh, it could be from anything. It could be from a biopsy, it could be from a bone scan, it could be from a CAT scan, that sort of thing.
Not just a high PSA though.
Not just a high PSA. A high PSA is not by definition metastatic disease, although often it is. So this is very intriguing, and so a lot of people are looking at maybe we should verify this and do a study going forward. But I found this very interesting because it really completely changes how we think about treating prostate cancer. And I think you'll see more of this going forward, that even if patients present with metastatic disease, that they're going to probably have their prostate still treated in some way if they're healthy enough to have it done. The next thing I'm going to talk about is the use of a new drug. Well, it's not that new, relatively new drug called Abiraterone in castrate-sensitive disease. Abiraterone is a drug that prevents cells from making testosterone, prevents their synthesis. Typically, as I told you, for people who have early metastatic disease, the standard of care is to give them androgen deprivation, and what that is, a shot that makes the testicles stop making testosterone. That's been the standard. And so just this month, in 2 articles that were back-to-back in the New England Journal, both were in different studies that looked at the same thing, and both came to the same conclusions, which I'll get to in just a minute. And so this is just a pictorial of where the sources of testosterone are. The testes is one source, and again, androgen deprivation typically blocks the testes from making any testosterone. The adrenal gland makes a little bit of testosterone. But then the prostate tissue itself, prostate cancer cells learn how to make their own testosterone to stimulate itself to grow. And so when you just give someone androgen deprivation, you're only blocking one of the 3 sources of testosterone. What abiraterone does is it will block the adrenal gland from making testosterone, and it will also block the prostate tissue itself from making testosterone. So you get far bigger drops in testosterone. Does it make a difference? And that's what these 2 studies were doing. So in both studies, they had one group that just got androgen deprivation, and the other group got androgen deprivation plus abiraterone, which is a pill. So in the one study, which is the stampede trial, this picture on the left is a graph of survival over time in patients. The black line is if they only got androgen deprivation, and the blue line is if they got both. And you can see that there is a significant overall survival difference favoring doing both. And this one on the right is not overall survival, but how long did they keep an undetectable PSA? Or actually better, how long was it before the PSA began to rise? And you can see there's even a bigger difference. Strongly favoring the abiraterone group. The other study, which was called the Latitude trial, basically showed exactly the same thing. The top is the overall survival between not doing abiraterone versus doing abiraterone, and the bottom is again the same thing. How long did it take before the PSA began to rise? Again, same difference.
Progression-free, I mean, the guy's already progressed. What does progression-free survival mean in this
It
case?
means progression from their... So when you treat, the cancer typically improves. And then at some point in time, it may start to progress. So it's the time for that progression after shrinkage. Basically time to where it appears that the drug is not working anymore. So one is how long you live, the other how long until the drug stops working. And so, again, to us, these are really big differences.
And this is a medication similar to Xtandi and Zantiga, or is it something quite different?
It is Zantiga.
It is.
But it is a Zantiga.
Yeah, it's just abiraterone is just a generic name for Zantiga.
What's on Xtandi?
Xtandi is a different medicine. Xtandi blocks the androgen receptor. It doesn't block testosterone from being produced, so its mechanism is a little different. That was not addressed in either of these trials. They only looked at Zytiga with prednisone, of course, or without it. But yeah, this is Zytiga. Up to now, Zytiga has only been approved to use in hormone-resistant disease, but this is the first data showing that it's highly effective if you give it right away, before you become resistant to hormones. Okay. So to kind of summarize the overall situation for castrate-sensitive prostate cancer, we really have two things now. 2015 was the big year where we found that chemotherapy helps in castrate-sensitive disease. And now we know that Abiraterone also will improve survival in castrate-sensitive disease. And this just summarizes the data that we know. The top two studies were the studies that showed that adding chemo at this point is helpful. And this hazard ratio, remember when I showed you if it's less than one's better, and if it's greater than one, the other is worse. So these were the hazard ratios for Taxotere. These are the two studies using Abiraterone. Again, hazard ratios very similar, so the benefit of this is almost identical to the benefit that chemotherapy provides. A lot of questions come out of this. First of all, that the standard of care, how to treat these patients, has changed. It changed in 2015, saying we should do chemo. Now it changed again, saying we should use 2 hormone therapies. And so we have very strong data that supports early use of either Abiraterone or docetaxel, which is chemotherapy, in newly diagnosed metastatic prostate cancer. What we don't know is, what about recurrent metastatic disease? What we're not sure is, well, which one's really better? Should you do Abiraterone or should you do chemotherapy? Or should you do both? Or should you do one and then the other? We have no idea, because these studies haven't been done, but these studies are going to be done. And we'll find out, hopefully in not too long a time, whether we should be just doing one, doing the other, or doing both, and if so, what order would be best.
What's the mechanism of the chemo drug? It's not blocking testosterone?
No, so the mechanism of docetaxel, usually it blocks cell division. So when cells divide, they need a scaffolding for the chromosomes to be able to orderly separate so that each side gets the equal number of chromosomes. And the thing that does that is called the mitotic spindle. And what the docetaxel does, it interferes with that spindle so it can't form properly. And so then the cell goes on to die because it can't divide very well. So it's a completely separate kind of mechanism. Yeah.
Is this only for men with metastatic disease versus men who have lymph node involvement?
So what I've shown you is it's all metastatic disease. We don't know if it's just as valid for people just with nodes or not. So that's an open question.
Is this a good time for discussion about the cost of these treatments and the toxicities of these treatments, or is that, do we not want to get into that?
No, we can get into that.
I understand that Abiraterone is not cheap.
Abirone's not cheap, and I have to confess, I do not know the exact price of it, but it is expensive.
Right.
The toxicity is generally related to having very low testosterone levels, so things like bone loss, potential cardiac things, erectile dysfunction. The side effects of chemotherapy are things like nausea, vomiting, hair loss, drop in blood counts, potential infection risks during the treatment. So the side effect profiles are very different. Another thing that's different is Abiraterone continues indefinitely, whereas the chemotherapy is a very defined time period that's temporary.
Right, but Abiraterone is relatively well tolerated, right?
Yes.
While the docetaxel is quite the opposite. A lot of people just really hate it.
It's not a fun drug. You're
Not a
absolutely
fun-
right.
Okay.
You're absolutely right. So personally, if I knew that both of them worked the same and that adding them together didn't help, and I only had one to pick, I'd pick Abiraterone. If I knew, which I don't, is if their effect is additive and I get a big bang for each one on top of each other, then I'd probably do both. But no one knows the answer to that yet.
So Abiraterone is, once you start taking it, the expectation is you would stay on it indefinitely
Until it
doesn't work.
Right. Yeah.
On that previous graph that shows,
Conclude my talk. The Gleason Score is being replaced by the gray group, and so you're going to start seeing, oh, I'm group 1, I'm group 4, and so at least you know what that means. That prostate cancer screening really does save lives. It saves 1 to 2 lives per 1,000 screening, which is pretty comparable to mammograms. However, you have to keep in mind that toxicity of treatment is not trivial. And then for newly diagnosed metastatic prostate cancer, we really should start considering treating the prostate gland, even though it has spread. We talked about the benefit of Abiraterone, we talked about the benefit of docetaxel, and the role of the combination at this point is unknown. That's pretty much all I had to say.
Good, very good, thanks.
Yeah.
Where would you put immunotherapy in this?
So immunotherapy, there's a lot of different things that are immunotherapy. So the only one that's really FDA approved and used regularly in prostate cancer is the Provenge, which is a vaccine. That is a form of immunotherapy. The thing that you see advertised on TV all the time is a different form of immunotherapy. These are what are called checkpoint inhibitors. There's part of the immune system that kind of puts the brakes and says, don't touch this. And what these drugs do is they take away those brakes. So now the immune system is free to start attacking things. So far in prostate cancer, there really hasn't been enormous benefit for the average patient. There's a few studies. There's a drug called Yervoy, which is not effective. And then there are these other called PD-1 inhibitors or PD-L1 inhibitors. There's a small subset of prostate cancer patients that seem to benefit, but it's a pretty small subgroup. And they're really trying to define how you pluck those out so you treat the ones that will benefit and not treat the ones that won't. But it's not standard of care right now. But it's being actively investigated. I think there was a question over here.
I had the same question
Oh, okay.
about prevention.
Yeah, so Provenge, I mean, it's still being used. There's another vaccine whose name is escaping me that's supposed to be announced later this year, whether it was a positive trial or not. So depending on those results, we may or may not have a second approved vaccine by the end of this year. We'll have to see. Yeah.
Can I ask you a question about finasteride? Finasteride is supposed to block the conversion of testosterone, so they're not usable before they go in by the gland. Is that a common treatment?
No. No, it really doesn't seem to be effective in treating prostate cancer. There was a study looking at it in terms of preventing prostate cancer, and that study was a positive study. It showed that if you take finasteride daily, that those men have a lower risk of developing prostate cancer. The benefit wasn't huge, and it's never really caught on because it's hard for men to take a drug like that every day to prevent something that's theoretical. The other thing is, at least in the initial studies, the people that got prostate cancer who were on it had a more aggressive, had higher Gleason scores, and so that kind of kept it from taking off. It just doesn't seem strong enough to prevent prostate cancer. Now, one thing it does do, it lowers the PSA. So if you're screening someone for prostate cancer, usually our cutoff is 4. Well, if someone's on finasteride, their PSA is going to be down just from the drug. So you really have to, your threshold should be more around 2 to do that. So sometimes I've seen people who are on finasteride who should have been screened long ago and never were because it wasn't understood that their PSA is artificially lowered by the drug.
Is Abiraterone the same as finasteride?
It's it's the same family. I can't remember, I thought it was the same family, but not the same drug. I don't use these drugs, so they're not used in prostate cancer.
Dutasteride.
I think, isn't finasteride Proscar? Yeah, that's what I thought. And Abigarerone's in the same family, but it's a slightly different drug, but I believe its mechanism is exactly the same.
Hey, folks, it's 8:10. We better give Dr. Geier a chance here because we're trying to put on
I'd
time.
like to first collect my wine from Dr. Mannion.
If I have your shill, sit down.
I wanted to, just before I started talking about radiation, which is what I'm going to pretty much do, I'd like to just mention one other thing that I think is a very interesting topic now in cancer treatment. It's a thing called the abscopal effect. And Dr. Mannion was showing the slide about treating the prostate if one already has metastatic disease, that's been shown to be, in this study, to be helpful in terms of survival. And there's a lot of interest right now in this abscopal effect. And I wanted just to read to you what the guy that made this up, discovered this, was back in the 50s. He was a radiation oncologist. And let me just read this to you. The abscopal, it's ABS-COPAL. The abscopal effect is a phenomenon in the treatment of metastatic cancer where localized treatment of a tumor causes not only a shrinking of the treated tumor, but also a shrinking of tumors outside the scope of the localized treatment, which, sounds like some kind of fantasia miracle thing, but it's been shown to be effective in melanoma, in kidney cancer, and that abscopal effect may be kind of what's going on here in this one study that Dr. Mannion talked about. We also think that the abscopal effect is mediated perhaps through your immune system, that it can start off an immune reaction to cancer that can be helpful. And so I think as time goes on, we're going to hear more about this abscopal effect and hopefully see treatments that work together to combat the cancer, not only locally, but systemically. So this is kind of a overview of some of the treatments we have at Christ Hospital and some of the treatments that we are going to be getting at Christ Hospital. The first one we have up there is the Calypso, which is a very interesting technique that helps us localize the radiation to the prostate and hopefully prevents damage to surrounding organs. And damage to surrounding organs is really the sort of rate-limiting aspect of prostate cancer treatment with radiation. So because the prostate is right next to the bladder and right in front of the rectum, typically those are the organs we have to be very careful with. So the Calypso, for patients that are not obese, allows us to put transponders, typically 3 transponders are placed into the prostate and they remain in there permanently. And those are used to follow the prostate during treatment. So in addition to that, we have patients fill up their bladder, so their bladder is full, and we have them do a bowel prep so that the rectum is empty. So we want as little of the rectum to interface with the radiation as possible. And by filling up the bladder, we can have a reproducible position in the pelvis for us to treat. But once we get the treatment set up, the prostate moves. Prostate moves all over the place. And you wouldn't think it would, but when you think of where it is, there's gas all the time in our colon that's moving around. There's stool moving around, so the prostate's going to move too. And we try to fill the bladder up so the bladder's not moving, and we try to have the patient's rectum be empty at the time of radiation treatment. But then once we fixate and once we get the beam turned on, we've got the technology at Christ right now that these transponders, we follow those during the treatment. And if the transponders move out of tolerance, the machine goes off. And then when they're back in tolerance, the machine turns on. So we think that this offers the patient an opportunity to have less toxicity from the treatment. And again, I said, patients can't be obese because the panel that we use to track the transponders fits over the top of the patient. It's basically on kind of like a tray system that goes above. It's on a stand that fits over the patient. But it enables us to, we think, give better treatment and hopefully prevent more toxicity. Another thing we're going to get at Christ very soon, and it's so soon that we didn't have it on the slide, is a thing called SpaceOR, which is a product that has been available for a couple of years. And as Mark Twain said, you know, things come to Cincinnati a little bit later than they do to other parts of the world. But Christ is going to have this soon, and SpaceOR is a very cool idea. What it is it's a hydrogel that is placed into a space that really we create between the rectum and the prostate. So instead of the prostate being right on top of the rectum, or the rectum being right on top of the prostate, we put in this gel in between, and it creates a space in between the two. So that while we're treating with radiation, hopefully the rectum is moved further away from the prostate, and we won't see as much rectal change. And you know, rectal change can be anywhere from patients having 2 or 3 bowel movements a morning when they previously maybe had a bowel movement every other day or every few days, to having radiation proctitis, which is a weakening of the bowel wall, so that when a stool goes by, you have a scraping and then intermittent bleeding. That's happens probably in about 5% of patients right now that we're treating. And that's a nuisance and a worrisome side effect of radiation treatment. And then for some people, they literally will have worse symptoms than that and need to take hyperbaric oxygen treatment to prevent or try to repair the damage from radiation treatment. But this Calypso technology is really wonderful. We think it's added a lot to the safety of the radiation, and this SpaceOR product we're going to be having available hopefully within the next couple of months, certainly by the beginning of next year, which will help us as well. I'd like to go next to brachytherapy. That's still a very, very popular and effective treatment for prostate cancer. What is brachytherapy? Brachytherapy is putting radiation inside the body. So talotherapy was what we typically would be talking about, which is radiation from the outside. So talotherapy with photons or protons is from the outside. Brachytherapy is putting radiation actually in the tumor, which we think makes a lot of sense. You know, to be able to put the radiation sources inside the tumor. So this is a therapy we still do a lot at Christ Hospital, and what we do is it's an operative procedure. It takes about an hour and a half to do in the operating room. The patient goes home that day, typically without a catheter. And what we are doing at the time of the procedure is placing radioactive iodine seeds into the prostate. And we may, if it's a primary therapy, meaning monotherapy for only doing the brachytherapy, we may put 100 seeds into the prostate. If it's therapy that we're adding on to external beam radiation, where we would do, say, external beam for 5 weeks, and then do brachytherapy, we may put in like 70 seeds. But it's still a very effective, very wonderful treatment for prostate cancer, and it's a therapy that we're still doing quite a bit of at Christ. Hypofractionation is basically, it says prior standard therapy. The word prior ought to be probably removed. The standard therapy for radiation treatment still today is external beam radiation, typically for 8 or 9 weeks. And that's, the NCI recommends that. It's still probably the most proven therapy that we have in terms of data. It's got the longest track record, and we know we can do it safely, and we know we can do it more effectively than we've been doing it in the past with these techniques with the Calypso and the SpaceOR, as I mentioned earlier. Hypofractionation is means fewer fractions of radiation. So what we typically have done with radiation over the past is use smaller fractions over a longer period of time. And what the hypofractionation does is we use larger fractions of radiation in a shorter period of time. So treatment can be diminished from, say, 8 or 9 weeks down to 4 or 5 weeks. And hypofractionation is here. There's a number of papers that show that hypofractionation is effective. There is some increase in toxicity when you use the higher doses. And typically, right now, we're moving at Christ to a hypofractionation scheme. In time here, once we get the space work program going, we're going to start doing fewer fractions of higher dose radiation. And we think we'll get the same outcomes as we would with the longer fractionation. This is another treatment that's still a little bit controversial. It's called SBRT. SBRT would be using 5 or 6 fractions of radiation, very high dose, to the prostate gland. So somebody would be treated, say, in like 2 weeks. And I just did, sorry.
That's CyberKnife?
Yeah, CyberKnife, that's
doing 5 days.
yeah, well, they might be. I don't know exactly what they're doing, but yeah, I mean, CyberKnife, they're doing that here at the urology group right now. And those are, using very high fractions of radiation. The data on that is still not as mature as the data on conventional fractionation. And the NCI right now basically says that you can do that. I mean, they don't, it's not one of their primary recommendations, but they say it is being done, and if you can do it safely, they basically say that they're okay with that. At Christ Hospital, we are going to probably be moving to this at some point. A bunch of us just went down to the University of Texas Southwest a couple of weeks ago for a 3-day symposium and had a very interesting few days there learning about how they do SBRT. So basically to do SBRT, what they do down there is they have the patients take an enema the night before the treatment and the morning of. So again, they're rock solid sure that the prostate is going to be in a stable position. And they monitor it as well during the therapy. So this is kind of the way the world of radiation is moving from kind of the more smaller fractions, longer period of time, down to bigger fractions with less time for the patient to go through treatment. And we do have technologies now that are allowing us to give much higher doses of radiation in a safer manner with fewer side effects. One of the things at UT Southwest that they did say was that they have all the patients sign a consent form that basically says, I understand that I am taking the risk of rectal toxicity from this treatment. Then they put their name underneath it in addition to the typical consent form they sign because of the concern of rectal ulcer. And the guy that was kind of running the show down at UT Southwest, a guy named Timmerman, is a very sort of outspoken radiation oncologist. Most radiation oncologists are sort of meek and mild. This guy's like kind of like a bulldozer. And he basically says, you can't cure cancer unless you take it right up to the edge. So if patients understand that they're going to have to incur toxicity for us to knock it out, most patients will take that risk and will say, okay, fine. I might get a rectal ulcer, but I'd rather have a rectal ulcer than have prostate cancer. And so anyway, that's kind of the way that some of the future is looking. Yes?
What's a rectal ulcer?
A rectal ulcer would be basically where a part of your rectum would actually have a crater in it that's created by a lack of blood supply to that area. And so it could be painful to have a bowel movement, and it could be also cause you quite a bit of discomfort, and also you could have intermittent bleeding, which could be very much a nuisance. That's why I said earlier that some people who do get these side effects, hyperbaric oxygen is an option for to try to heal that.
Is that different from radiation proctitis?
It would be a more severe type of radiation proctitis. Yeah, radiation proctitis would be something that occurs where a patient would have maybe some, probably no pain, typically with radiation proctitis, but would have some intermittent bleeding, so like blood on their stool, maybe for a couple, 3 bowel movements, or maybe for a few days. It goes away, it comes back 6 weeks later, it goes away, it comes back, a month later. So it's one of those things that's kind of a chronic recurring problem. But typically, patients that have it, in my experience, manage it pretty well. And one of the reasons that I typically have people get colonoscopies before we do radiation treatment, if they're not up to date on their colonoscopies, is to make sure that they don't have anything else going on that could be causing bleeding. And if they've had a clean colonoscopy and they start bleeding intermittently with blood on their stool, 6 or 8 months after we've treated them with radiation, we're pretty confident it's a radiation complication. It's not a colon or rectal cancer. Yes, sir.
In your opinion, what's moving us towards more high fractionation? Is it cost or convenience? On first take, it seems to me like we're taking a lot more risk just for those reasons, keep it off of that.
Yeah, well, there is more risk certainly with side effects. But the other reason that it's interesting, and the other reason that there's a movement towards this, is there's data that shows that higher fraction sizes of radiation, say radiation giving like 900 grads or 900 centigrade in one fraction, has a much higher biologic effect in terms of cell kill than if you're using, say, what we're doing right now, which would be 180 or 200 centigrade a day. So it'd be 900 centigrade, like times 5, Monday, Wednesday, Friday, Monday, Wednesday. And the idea is and this guy at UT Southwest, that bulldozer guy I was talking about, is very much into this, in the fact that, we're not here to mamsy-pamsy with cancer. We're here to kill cancer. That's our objective. And if we're gonna do it, let's not play around and just do the gentle stuff. Let's really go after it. So there's radiobiological data that shows higher fraction sizes give you more cell kill. So that'd be one of the reasons to do it. The other would be that if patients could get treated in 2 weeks versus 9 weeks, who wouldn't go for that? So but the downside is there is more risk. So the side effect profile is worse, certainly with that.
Will it take some time before we know what was the better way to go?
Yeah, we're still in that process right now. Yeah, I mean there are people out there right now that would love to come in here and tell you that this is the way to go for everybody. And the guy at UT Southwest says that. He says this is baloney that you're still treating people with conventional fractionation. But I think that most people in our country, or a lot of people in the U.S., in terms of radiation oncology, and ASTRO, which is the National Society of Radiation Oncology, really still hasn't come out in favor of this across the board. So,
When you say with the CyberKnife there's more risk, what are the more risks?
well, the more risks are what I was just mentioning, the rectal ulcer or damage to the bladder. Those are the two organs that typically, are right there next to the prostate. So those would be the organs at risk. And that's where that spacer thing I was talking about earlier comes into play. Because if we can create some more space and push the rectum away from the prostate, then we have a little more of a border in there. But those would be in CyberKnife or any radiation treatment to the prostate, those would be the two organs we'd be concerned about. Yes, sir.
Well, those become possible because the machines are better, you can target it better,
That too, yeah. I mean, the targeting right now is much superior. Say, I've been doing this for about 29 years, and the machines and the way we treated radiation or prostate cancer when I was a resident doctor, now it seems like, almost like caveman stuff. I mean, we just used to set up, big fields and let it go at that. And we weren't doing that because we were being sloppy or negligent. That was the best technology we had. But now we've actually got, on these treatment machines, we've got CT capability on the machine. So the therapist, instead of just, looking at a console that has, looking at the patient actually on the table, and the only time they really knew what they were doing was when they set up on the marks on the patient. Now they're actually looking at a CT scan that's taken right then of the patient on the table. And they can overlay the treatment isodoses on the patient's, on the pictures that are real time, right there with the patient there. So they can move the patient around and get it just down to, into millimeters in terms of precision. Yeah, so the technology today is out of this world in terms of what we have, and it's only getting better. Yes, sir.
Are you doing any, like localized metastatic, you're just talking about treating, the prostate. I mean, anybody who's, metastatic cancer that gets scanned with we've heard about Faraheen scan and different scans to light up the cancer that might be either still in your prostate bed or maybe on another bone. Are you doing any localized radiation treatment that way?
Well, we do a lot of localized radiation treatment for metastatic disease. Yeah, but we're not at the point yet, but we will be. My daughter's a radiation oncologist, and she's going to be starting her career in about a year. And my guess is by the time she's where I am, we'll be treating not the entire prostate, but we'll be treating part of the prostate. We won't be treating the whole thing. And so the treatment will be even better and have even fewer side effects than we have now. But yeah, we do radiation a lot for metastatic disease, and we are able to localize it a lot better. Bone scans, we can overlay those. PET scan particularly is very helpful to us in terms of being able to localize metastatic disease and be able to treat it effectively.
I don't know if you want to comment on radiating the prostate bed when that's, because you do that a lot as well.
We do, yeah. So that's another option we have for patients. So a lot of times patients will have a radical prostatectomy, and over time their PSA will start to kind of creep back up, and we'll do scans, the bone scan and a CT scan of the abdomen pelvis to try to determine if they have metastatic disease, and we won't see any, but the PSA continues to go up. So what we'll often do in that situation is we'll give radiation to what we call the prostate bed. The prostate bed would be where the prostate was before it was removed. And so we treat an area around where the prostate was previously. We don't give as high a dose as we do for primary prostate cancer. But probably in about 70%, 60 to 70% of patients will get a stabilization of their PSA or a decrease in their PSA for a couple of years typically. It might be a little bit longer than that, it might be a little bit shorter than that, but about 60 to 70% of patients will respond to that treatment. And again, the precision of the radiation today is very helpful in that situation as well, because we're talking about really tight spaces now, because the prostate's been removed, the bladder and the rectum are sort of right on top of each other. So to be as precise as possible is really, really helpful in terms of cutting down on side effects. Yes, sir.
You mentioned a couple times that radiation treatment using seeds is, I think, quote unquote, still being done at that price, like it's fading away. What factors come into play to decide to use that?
Well, let me explain the fading away part of it, because it's not fading away as far as I'm concerned, but on a national trend, it is fading away. So the interest in it is waning, and it's really because I think it's kind of complicated to do. It takes a lot of moving parts. It takes a physicist, it takes a radiation oncologist, it takes the urologist. You have to, everything's done in real time, so it's in the operating room. It's just a lot going on to have it come together. So I think from the standpoint of difficulty in terms of achieving a good seed program, it takes a lot of doing. And I think a lot of places just don't have the interest in it. No, we're still doing a lot, and I still think it's a very, very good treatment. And if that guy I was talking about down at UTSW, or I went to a review course up in Chicago at the end of April, or beginning of April, for Astro, and they talked, the guy that presented prostate at that review course said the best treatment for prostate cancer is a radioactive seed implant. So, and the guy at UTSW said that too. But then they go on to say that, you know, most places don't do it anymore. It's hard to find a place to learn how to do it, and, you know, it's kind of a fading art. So, you know, I have to do a sociology kind of study to see why people don't want to do it in terms of the professionals. But I think it still has a lot of appeal. You know, we're able to put an enormous amount of radiation in the prostate with these seeds versus what we can give from the outside with any modality. So, you know, I still think it's a really good treatment. Yes, sir.
Is that last bullet there,
It's a big one.
is that, are you radiating the spot itself within the bone, or?
That's actually a treatment we do where we give a radioisotope that goes throughout the body and treats metastatic prostate cancer. So it's basically an injection.
So you inject it, it circulates, and it gets taken up by the bone. And so it sticks to the bone over the whole skeleton, and then from there, the radiation is released. And so the entire skeleton gets radiated, but not all the normal tissues. But it doesn't really know where the cancer is, it just radiates all the bone.
It's an isotope of radium, isn't it?
Yes, it's radium-223.
Yes, sir.
I have heard about a new test that I think it's with radiation, some kind of isotopes and so on, for people who have had radiation and have been zero PSA for a long time, and then it begins to go up. And that this new test shows, lights up where the cancer now is, and then the possibility is that you could focal the radiation on those few spots, or a single spot, to kill the cancer just there. Is that something that's being done, or am I not talking right?
I think what you're talking about is just a better way to image. So right now our imaging, the standard is CAT scan, bone scan, and standard PET scan. But a PET scan is where most places where you inject radioactive sugar, and you see where does the sugar go, because cancers use more sugar than normal cells. The problem is, especially when you're looking for something small, that's not always sensitive enough. So what people have been playing with is, can you use something different than sugar? And maybe you can see a smaller cancer with the PET. So I think what you're referring to is this radioactive fluorinated amino acid. It's FACPC. It was just FDA approved in the last year or so. And the theory is that if you inject that, you can see smaller cancers, and then you know where to radiate. But it's an imaging technique. Not all places have it yet. We're hoping that Christ will have it in the fall. This specialized form of a PET scan. It's basically a PET scan.
Are you talking about 68 gallium PSMA?
No, well, that's another another way to look for prostate with PET, but I don't think that's FDA approved.
It's a clinical trial now.
Yeah. What I'm referring to is it's already been FDA approved. I think it was.
Axum? You talk about Axum?
Yes.
Isn't there choline 11?
Well, choline 11 is another one. There's all different things that you can inject that are radioactive. To my knowledge, the only ones that are clinically available outside of clinical trial would be the fluorinated amino acid and then the sugar, which has been around for years. But the C11, choline, all these are all things that are up and coming that we're not sure which ones are going to end up being the most useful. Sir?
Your bag of tricks, are you thinking about bringing in things like high school, I mean, a cradle or anything like that in the near future, or is that?
In my bag of tricks, no, but there are people at Christ that do the cryo. We use that as a salvage therapy sometimes for localized disease. So we do have that at Christ. We don't have HIFU there, but we do have a cryosurgery, which is freezing the prostate. Yes, sir.
Earlier we looked at all these Kaplan-Meier curves. What would be your set of Kaplan-Meier curves from your practice? In other words, have you looked at a successive radiation therapy versus, say, Gleason or this new grading system?
I have. We haven't looked at our own data. We're still trying to get that together. But we will hopefully have some data here before too long. In terms of national data, worldwide data, the treatment for prostate cancer, I think, still is equivalent between surgery and radiation. So what I typically, and so what Brian was showing earlier with the different Gleason scores of prostate cancer. So typically the survival for the various Gleason scores, survival would correlate with that. So if you have a Gleason score of 6, your survival at 15 years would probably be in the 95% range, maybe higher than that. Gleason 7, 3 plus 4, your 15-year survival would be less, probably in the 90% range, and then on down. So I think radiation treatment, there is certainly data that shows that radiation is an effective treatment for prostate cancer, and it varies depending on the Gleason score, and obviously the degree of tumor burden when a patient shows up. So if somebody comes in and they've got a Gleason of 8, but they only have one biopsy that's positive, we think of that patient as having a better prognosis than somebody whose prostate is chock full of Gleason 8 cancer. So my answer to that would be yes, I think there is data that shows that prostate cancer does respond well to radiation. And this SBRT stuff, the early data, the data from animal models shows a significant improvement in response of the cancer to radiation treatment.
I guess one of the reasons I'm asking is because there's so many kinds of radiation now, and you mentioned some of them, but not all of them. I mean, I guess what you guys use is EBRT, right, typically?
External beam radiation.
Yeah, I mean, there's IMRT, there's
Well,
SBRT, there's a bunch of them. There's DART.
IMRT is the same thing as EBRT. It's a type of external beam radiation.
Right, but it's intensity modular.
Exactly.
Okay, but so there's probably a dozen radiation modalities, some that you've mentioned, some you haven't mentioned. And they all have different profiles for, efficacy and toxicity. How is a guy supposed to decide?
Supposed to probably come to a meeting like this.
Yeah.
I mean, that'd be a start. I think I would ask, if I was diagnosed with prostate cancer, I think what I would do is I would go around and talk to several different people that have these different modalities and ask them, what are you seeing as side effects? What are my chances for cure? And I think if you compare the different modalities, you can get a better idea about it. But it is confusing, and I'm sure it would be mind-boggling. That's why what Brian was talking about earlier about the prostate collaborative we have. We're sort of bummed that more people aren't coming to this because we think it's a great opportunity to come talk about these things.
Sure.
And if you're not sure if you want to have surgery or radiation, you got the radiation guy sitting there and the surgeon there, and they're going to talk about it. They can each give you their best spiel about what they think is better for you. Or the radiation guy might say to the surgeon, to the patient, I think for you, I think surgery would be better. So there are patients I think that surgery is a better modality for. You know, one of the things that we haven't talked about, but radiation treatment, if we give that up front, typically then patients are not able to have surgery because most surgeons won't want to operate on you if you've had radiation. But if you've had surgery and the surgery doesn't work ultimately, we can then go back, as I said earlier, and we can give radiation to the prostate bed. So oftentimes, if I'm seeing a patient who's like my age or younger, you know, and everything's equal, and they can't make up their mind, you know, do I do surgery or radiation? You know, I'll say to them, you know, if you have surgery, we have radiation as a backup if you need it. But if we do radiation up front, you can't go have surgery, you know. And a lot of times that'll help patients make that decision because it gives them a, you know, kind of a fallback. But you know, I think we all understand it's really complicated trying to figure out what's what. But I would also say to you that I think of the radiation modalities that we've talked about, and you know, CyberKnife would be one of them too. You know, I think that not one size fits everybody, but I think there are treatments that I think are suitable for each patient. So I think if you do talk to your, you know, oncologist, your radiation oncologist, or your urologist, and I think most patients, I think if they meet with each of those doctors, they can figure it out what seems right for them.
I think one of the problems that it's hard to have, you know, Kaplan-Meier curves and all for everything is, I think first of all, there's never really been a radiation versus surgery randomized trial.
We'd love to see one.
Where patients were randomized to one or the other in terms of getting absolute definitive data. But if you look at the national data that people are treated either way, the outcomes are so similar that I think for practical purposes there's very little difference. And then the other thing is there's so many choices and there's so many new sort of tools and whatnot coming out that they're coming on board faster than you can do the trials to compare them all. And so there is this lack of rigorous doing A versus B, A versus C, you know, because there's just not enough time to do it all. In the meantime, you know, 4 new things have popped up, 4 new therapies.
Let's take 2 more questions, and then we'll conclude things. Yes, sir.
Would you want to comment on proton beam radiation?
Yeah, proton beam radiation is a highly effective form of radiation. Has a very attractive component of it, which basically allows the radiation beam to give very little entrance dose, treats the tumor, very little exit dose. Whereas what we're doing right now with photon radiation, the radiation penetrates through and through. Now, so proton therapy is very, very, very effective for certain things.
I had it 9 years ago.
Oh, that's great. And it's also very appropriate for pediatric malignancies. So in the pediatric population, about 60% of their tumors are CNS tumors. So they get tumors in the brain and the spine at a much higher propensity than adults. And it's very effective in that age group because of they're developing, their bodies are. So to not be able to give a lot of entrance and exit dose is really effective and helpful in terms of not causing deformities in these kids in these very sensitive areas of their body where they're getting treated. But proton therapy is a great treatment, and it works for, you know, works just as good as photons. Now, I will say this, that photon therapy, which is kind of the garden variety of radiation that's out there in the world, because of the IMRT, the intensity modulated radiation, which is an opportunity that we have now where the radiation isn't static. The machine is moving while the patient's being treated. So what happens then is the dose gets distributed around the body so that not any part of the normal tissue gets a significant amount of dose. So a lot of people think, well, that makes photon radiation, you know, appropriate as well today because of the fact that there's fewer side effects from it. But proton radiation is terrific, and you know, you've got a center out at Liberty Township now that Children's and UC have put together, and hopefully some really important vital research will come from that, as well as some great patient outcomes.
kind of question here that relates exactly to that and what you were talking about regarding Calypso. But you could probably get a lot more if just the first 2 or 3 sentences there than me trying to decipher it there for you. I've been puzzled about that ever since I read that.
Dear Dr. Geier, on behalf of the cancer support community, we'd like to buy you and your wife dinner. Both. Thank you very much. Let's see. Let me talk with you about this afterwards. Okay. Yeah, that'd be great. Last question.
So we saw a protocol discussed in the first part with Dr. Mannion about the Zytiga, I guess, approach. So you're on that path. When you get an MRI that says you have a specific lesion on a certain part of your lumbar, would you complement that first treatment with a specific radiation to that point? Or would you let the treatment continue without the radiation?
That's a good question. So right now, where we currently are, we probably would not do radiation unless you were symptomatic there. If you were having pain, we would. Or if you're having some neurologic problem from it, we would give radiation. But with that abscopal effect I talked about earlier, as time goes on, we may find that treating those lesions is important in terms of helping bring the immune system to life. So currently, right now, we would only do it if you were symptomatic or if you were having some sort of side effect from it. But down the road, we may be looking at that.
There are some clinical trials looking at what we call oligometastatic disease. So oligometastatic is a term when you have metastasis, but it's very invasive. There's only 1 or 2 spots. And so there's a lot of interest in should you be really aggressive and treat those spots with local radiation. And so the answer is not no, but there are trials going on that are looking at that. There's a lot of interest in could it work?
Thank you all.